super happy. But what happens to the implants? Because it is a terminal implant there, the overload osteolysis will start. Remodeling of the bone will happen, implant will fail there. What I am telling, the implant should be in the back here, implant should be in the front here, the force should be in the center. Then what happens? The force gets distributed to the anterior implant and the posterior implant. Then the chances of success is 100%. It will not at all fail. It will work indefinitely over a period of time. So that is the reason why we want to do that. I just spoke to you about the shortened dental arch, why we should not do it. So even if I am having more teeth in the back on one side, less on the other side, I have to give occlusion only molar to molar. We don't go beyond 6 to 6. 7 you go, you are looking at problems in case of cortical implants. Class 3 lever principle, it will move the tooth, it will break the tooth and so on and so forth. I just spoke to you. I already spoke about the supporting polygon, which is second molar, canine second molar. So it starts from 7, 3, 3, 7. So you imagine when I am loading the implant, it should be inside the supporting polygon. When it is inside the supporting polygon, the forces are intrusive, the framework does not flex. The moment it is outside the supporting polygon, if this is the polygon and I am giving force outside, the frame has a tendency to get compressed on one side. It is trying to lift up on the other side. Wherever there is a lifting force, the implant will start the failure from there. Disuse, tension force, compressive force is osteolytic. Now, then why it happens is because the compressive force is more acceptable than the torquing force. This becomes very significant when we place the implant and we are loading on one side to the other. So what is the concept that we are following? The Bull's law. Upper buccal, lower lingual are the non-working cusp. We don't need it. We reduce it. Can you see here? When it is equal and I am placing, let us say, an implant in the lateral incisor, I don't place in the canine, instantly one side, the supporting polygon became smaller, thereby the position or the buccal cusp of the lower came outside the supporting polygon, or even if it is the upper, it came outside the supporting polygon. Once it comes outside, the loading will be unequal. It will fail eventually. So what is it? How do I do this? Can you see? One is, this is the lower, upper, okay? When you look at the lower, what is the contact? First premolar, second premolar, mesial half of first molar. Inside the second premolar, can you see in the center, is the central groove. What is that contact? That is the palatal cusp of the upper is sitting in the central groove of the lower. We are not seeing the opposing of this here. This buccal cusp is going and sitting in the central groove of the upper, and palatal cusp is sitting in the central groove of the lower. So now what are the cusps which are not necessary here? Is the Bull's law. In the lower, compulsory when the jaw is moving to the right side and to the left side, when the jaw opens, always the muscles of mastication which are working, the muscle which is opening the jaw is different from the muscle which is closing the jaw. Correct. Muscle which is opening the jaw is the lateral pterygoid and the suprahyoid muscles. So when the jaw opens forward like this, okay, when the jaw is closing, masseter temporalis, medial pterygoid pulling the jaw inward. So the jaw, what opens outside, closes inward like this. So you will see the Possel's arc will be forward like this, backward like this. When that happens, the contact between the upper and lower should be very, very clean and clear one, single contact. that single contact is the bilateral equal contact, but that is during occlusion, which means what? It is static. I bring it, I am checking where is the equal contacts are there on both sides, but it is a static contact. Okay. Now I want to check when he is eating, dynamic contact. What to do now? When the dynamic contact happens, I am taking an articulating paper, make it into a ball. Primary what I will do is the static contact. This contact, let us say this is in red color I took it. For example, static contact. Dynamic contact, I will put a blue color paper and I make him chew. When I am making him chew, the contacts are coming everywhere. When you apply the Bull's law, what should I remove? I should remove the buccal cusp of the upper, and lower lingual cusp is not necessary. I simply close my eyes and remove the lingual contacts. I will remove the buccal on the upper. So now I am having only contacts on the lower buccal, upper palatal cusp, contact is there. Now is this contact equal? If this contact is equal, I should have marking on both sides of the 3 teeth equally. Suppose one side is very faint and one side is very dark. Then what happened? One side is more contact, this side is less contact. So will I reduce? Will I reduce? I don't know. What I will do is I will go measure the vertical height first. Correct? Suppose I reduce it and I reduce the VD, because now those are the functional cusps. Those are the cusps which are holding the vertical height. If I reduce the vertical height, is it acceptable? If it is within the 2.5 up to 4 millimeters, see how much is the freeway space? It is said that between 2 to 4 millimeter is the accepted freeway space. Suppose it's already at 4 and I go reduce the height, became 5. Not acceptable, because now you are bringing it into forward contact, because the lesser the vertical height, the more protrusive the contact. So primarily what I will do, I will measure the VD first again. So all the time I am going back to mark the point again VD. Check the rest position. Now Niswanger's method, after I fix the restoration, becomes very difficult to manage. Then what to do? Silverman's closest speaking space. What is that? Mississippi, 66. So when I am saying 66, air is escaping, upper and lower teeth should not touch. If they are not touching, my VD is okay. If they are touching, VD is more. I have time to reduce. I can coolly reduce the height and go with it. If they are too much of gap, 66 gap is so much more, then again I go back to Niswanger's method to reconfirm. So I am using phonetics, I am also using aesthetics. Okay, I measure and confirm both and then say, okay, if now equal contact is not happening, on the side which is not contacting, I will put the self-cure or I will do some other treatment to increase the height. Once I increase the height, again check the static contact. I should get equal only in relation to the functional cusp, which is buccal of lower, palatal of upper. Okay. Then after that, I put the articulating paper inside the mouth and make him chew. He has to chew it like a chewing gum or a palm supari or something like this. Okay, he's converting it into a ball. When he is chewing that, there are various contacts are coming. What will I reduce? Wherever the previous red mark, which is static contact, to dynamic contact is coming, I will not reduce, because those are the vertical stops. The rest of the contacts are extra contacts. I will simply remove the canine. Anterior contacts I will remove, posterior contacts I will remove. Wait, see, I told you, no, to maintain it into a class 3 lever principle, I will remove distal half of molar, I will remove. Anterior canine to canine contact I will remove. Now nobody asked me why you should not give anterior contact. I will answer this myself later, but I am telling you. So only 3 teeth contact. So which means palatal cusp, palatal cusp. Now buccal cusp contact. Here all red color I have marked. Okay. Only this I put the blue color. When the jaw is moving from the right side to the left side, the palatal cusp of the upper, the buccal cusp of the upper is coming in contact with the when you apply the Bull's law, is not necessary. Okay, we should not have contact on this. This buccal cusp sits inside the central groove here. This palatal cusp sits inside the central groove here. Okay, this is the only contact I require. So now when the jaw is moving to the right side and to the left side, this buccal cusp has a tendency to touch the palatal slope of the upper buccal cusp. This will come here and touch and then move like this. What is canine guidance? Canine is the jaw moves to the right side. The palatal slope of the canine is guiding the mandible to move to the right side, and this canine is guiding it to move to the left side. Okay. Now the similar thing happens in the posteriors. If it only happens in the canine, it's called as a canine guidance. Along with the canine, if the premolar and the molar buccal cusp is guiding it, it's called as group function. So, should I maintain group function? Because the moment we are talking about Bull's law, this should not there, no. I don't want contact in the buccal cusp of the upper. I don't want contact in the lingual cusp of the lower. Then what is happening? Single cusp is coming and sitting in the central groove. The single cusp contact is called as lingualized occlusion. This lingualized occlusion was first described by Geisy in the year 1927, and today till now it is found that it is the most reliable type of occlusion that you can give for any full mouth rehabilitation. Lot of papers have been presented. Please Google it. There is a one guy who did a lot of studies. If I remember his name, I'll tell you. But we are removing this and this. We want to do lingualized occlusion is the only concept we want to follow. Why? Because when the jaw is moving to the right side and to the left side, the hindrance from the palatal slope of the upper buccal is not there for the jaw. What is that hindrance? That hindrance is called as a interference. Why is it an interference? Because when the jaw opens and closes, during the closure, if it is coming in contact with any other cusp posteriorly, thereby changing the class 3 lever principle into a class 2 contact, then it becomes an interference or an unnecessary contact. We simply remove that first. This is the concept. This is something you must internalize. This is something you must work upon over a period of time. It will not happen tomorrow, day after tomorrow. You should remember what I am saying, note it down and say, okay, this is the concept. Please use it and see. When I make a full mouth rehabilitation, I am putting 28 crowns, crown and bridge. I am putting 28 crowns. Today that guy is having simply adhered teeth, and I am raising the height by about 7 millimeters straight away, and I am giving a final prosthesis with zirconium from 0 dermal, I am giving it into a zirconium prosthesis. Will there be pain? Will there be nothing? The force will be perfectly distributed and there is no lateral contact. So there is no interference at all. The patient will be super comfortable, and that is the way to do a full mouth rehabilitation. I can tell you that with conviction.
So why do we want good function occlusion if we are able to achieve canine guidance?
Canine guidance is when canine is present. Okay, canine is one single tooth. When we are doing a full mouth rehabilitation, canine guidance is absolutely contraindicated, because how can I give a single tooth contact on an implant based restoration for a natural tooth? If there is already canine guidance present, I will not disturb it, but I will not try to create canine guidance. It should be organically already present. I will not disturb that part. But if I want to go and create, I can only create group function, because I am distributing the lateral forces on a set of teeth. Let us say from premolar and mesial half of first molar. Or I am also, if the canine is present, it's good luck. But I will not bring the canine into occlusion. Okay. The question you asked was, why will I do group function? You need not do lingualized occlusion. Simply remove the buccal of the upper. Make it flatter. When we are making a denture, you have lingualized set of teeth. Those are very expensive teeth sets. You pick up that teeth set, if you see, the palatal cusp will be more prominent than the buccal cusp. It will be mild shade compared to the palatal.
To make the natural function.
To sit in the central groove of the lower. The palatal will sit in the central groove of the lower. The buccal of the lower will sit in the central groove of the upper. Now comes the question, after doing this occlusion, will this match the supporting polygon that the implants have placed? Bone is there, maxilla is there, mandible is there. There is a resorption pattern. Resorption of the mandible brings it more buccally, makes it more wider. Resorption of the maxilla makes it more smaller. I place the implants, then I make a framework, and I am telling I want the cuspal contact to be exactly at lingualized occlusion. When you imagine where I am going, the amount of work that needs to be done is seriously well planned. It's not a random thing. You cannot get it. If you do random work, you cannot get that type of occlusion. Simply.
First one.
Sir, thank you.
Sir,
actually canine guidance gives more force on a single tooth than a group function, and it's there's much more less in a lingualized occlusion.
There is zero. It will be completely compressive force. Talk, it will come and
So
sit.
if you give canine guidance in an artificial prosthesis, it will dislodge it, and it's
See, even if it's a bridge, natural teeth bridge, it will fail. You will find bridges are failing because of canine contact.
sir, is a lingualized occlusion or a group functional occlusion, which will be preferred for natural teeth full mouth rehabilitation? Lingualized.
When you see the contacts, when the jaw is moving, right side, left side, when he is chewing, for you to get the working cusp contact and the lateral movement contact on the palatal slope of the upper buccal cusp, which is this contact, this blue mark, and for it to be equal on both sides is a big task. When he comes back again after 2 weeks or 2 months, depending on the material that you put, if you put a very soft material, again you will have contact everywhere, again your brain will get freezed. So the easiest thing is whatever the respiration, lingualized occlusion is absolutely easy to attain and you can maintain it over a long period of time. The point being, there is only one cusp. After some time, what happens? If it is a soft material, say acrylic or composite, that will become flat. So lower is like this, it comes and sits. If you take a glass plate and you press it on a certain morsel of food, you need more force to compress it. If you take a sharp cuspal pattern and smash it, the food will get smashed easily. So what am I saying? The moment it becomes flatter, you have to rework on the cusp, because if it is flatter and flatter, the force the guy is using to chew his food is more higher and higher. Overload osteolysis will happen. So you got to be careful. So after the implant placement, the next most important thing is the material of choice that you do. I want it to be optimally strong enough so that I adjust the occlusion and I don't want to see this guy. He's out, he's finished. You just simply call him for a recall, check occlusion, put the articulating paper, chew it. Is it having any extraneous contacts apart from my contacts which are allowed by the Bull's law? I follow the Bull's law strictly. Simply follow the Bull's law. It's awesome technique. After that is nothing.
Sir, the three contact distance, 3 molars, premolars and this law.
First molar.
It's only for the bicortical implant concept or for the full mouth rehabilitation for the natural.
You can use it indefinitely for any type of respiration.
Thank you.
So, when you compare the ideal occlusion, which is the natural occlusion, you have CR is equal to CO. What is that? When the jaw opens and closes, the occlusion should happen smoothly. If it comes and touches one cusp and then sits inside, it is called as a hit and slide. Hit and slide is your centric is somewhere, but your occlusal contact is somewhere. So what will happen? So its centric is here, but it has to slide into occlusion here. Centric position, the condyles are at rest position. Here when it comes, the condyle, this occlusion is dictating the position of the condyle inside the glenoid fossa. Position is changing. That mild change in position is making one side flaccid, one side muscle is extended. Instantly, the patient will not be comfortable. Sir, everything is good, I'm eating fine, everything, but I'm not comfortable. This hit and slide is the problem. So, in natural occlusion, naturally it is present. CR will be equal to CO unless there is a major malocclusion. What is this posterior disclusion? Whenever there is a anterior contact, posterior will be discluded. That is the Christiansen phenomenon. Automatically there will be a triangular space. In case of our implant restorations, what am I saying? I want a lingualized or a group function occlusion and bilateral equal mastication, which is centric contact should be equal, lateral movement is by virtue of the lingualized occlusion, and anterior contact is not there at all. So what happens? What happens to incisal guidance? What happens to canine guidance? What happens to group function occlusion? These are all things are not there. Then will your restoration fail? Will there be a problem? Anterior guidance is what? Lower incisor is sitting on the palatal slope of the upper tooth, and when the jaw opens, I told you the muscles of mastications are different. So when the jaw opens, the lateral pterygoid is pulling it forward. There, the incisal tip is following the slope of the palatal cusp, palatal surface and opening outward. Okay. In case of unobstructed envelope, what am I saying here? This is the anterior guidance. I am saying there is also a posterior guidance. What is the posterior guidance? Posterior most contact of the mandible inside the glenoid fossa is the temporomandibular joint. How does it function? by virtue of the condyle inside the glenoid fossa. There is a articular eminence, there is a articular disc, there is a synovial fluid, it is a mechanical joint. It is opening and closing. It's a inclino-arthroidal joint. It will adapt according to function. How is it happening? The motor which is moving the joint is the muscles of mastication. What is this? This is a standardly present when the patient comes to you. Every patient has a temporomandibular joint. He is having muscles of mastication. They are working. He is having teeth or no teeth. He is still surviving. So there is a certain amount of function that this muscle of mastication is doing for even a edentulous fellow of 15 years. Still it is working. That guidance, that joint and the muscles of mastication are enough to maintain the occlusion for a permanent solution with a full mouth rehabilitation. We do not need anterior guidance because the anterior guidance is unreliable. Anterior teeth may be present, may not be present. Anterior teeth may be strong enough. They are mobile teeth, they are supraerupted teeth. We can't go into those combinations. We need to have something solid or there is a constant presence. I cannot say my occlusion is now going to be what concept to do because it doesn't have incisors. Where will you go? You simply follow one concept which is posterior guidance. That's all. So we don't need anterior guidance. Okay, that brings me to the end of the discussion. Whatever questions you have, I am ready to answer. Sir, you wanted photographs and cases, no? Can I show some cases?
We will do it after lunch, sir, because 1:30 will close for lunch.
Okay.
Maybe after that we can have a question session, sir.
Okay, now lunch.
Yes, direct lunch.
Awesome.
Thank you, sir.
Thank you.
Thank you, sir, for an explanatory lecture.